So dynamic CVP assessment. So what I mean by dynamic CVP assessment is not just using a single CVP measurement, basically the end expiratory end of the A wave CVP assessment, but rather looking at how the CVP changes in response to changes in intrathoracic pressure, because as we just saw, the cardiac function curve shifts with changes in intrathoracic pressure in response to the systemic venous, relative to the systemic venous return curve in response to changes in intrathoracic pressure. And so that whether or not there's a change in CVP with respiration may actually tell you whether or not you're on the plateau of the cardiac function curve. So as we saw in the last section, static measurements of CVP are not really adequate markers. They're okay for volume responsiveness, so therefore changes with respiration, that is dynamic assessments, may be helpful. And we just talked about this. The physiology is that the cardiac function curve is shifting from respiratory variation. So the key thing here is the absence of change in CVP with spontaneous inspiration is a pretty good marker of the plateau region of the cardiac function curve, and therefore preload intolerance, okay? So why does this happen? Well, we've talked extensively about this already, that this is your CVP. It lies at the crossroads of the venous return curve and the cardiac function curve. So this is your right atrial pressure, your CVP, this is your cardiac output. So decrease in intrathoracic pressure with this, say with a spontaneous inspiration, will shift the cardiac response curve to the left, okay? Decrease in right atrial pressure from here to here, but an increase in cardiac output. Okay? An increase in intrathoracic pressure does just the opposite, right? It shifts it rightward, so now you've got a higher right atrial pressure and a lower cardiac output, okay? So now imagine this cardiac function curve. So you're clearly on the plateau here. This patient is going to be a fluid non-responder. If you move their venous return curve to the right by bolusing them, increasing their mean systemic pressure, you're just going to get a higher right atrial pressure and no cardiac output. So what happens if this patient breathes in? Okay, this is the right atrial pressure. They breathe in, moves leftward, but the CVP doesn't really change. And this is a unique characteristic of the venous return curve intersecting the plateau of the cardiac function curve. So a lack of change of CVP with spontaneous inspiration is a pretty good marker of volume intolerance. Okay? But caveat to this is you can get a false positive of this effect. Or I guess I shouldn't say false negative, maybe a false, or I shouldn't say a false positive, I should say a false negative, if there's active expiration. Again, we talked about this earlier about measuring static CVP, is that the patient cannot have active expiratory efforts, which raises intrathoracic pressure. Why would that occur? So say this person is bearing down on expiration. Well, they can push their cardiac function curve all the way to the right out here, and now you're actually intersecting, because of that increase in pleural pressure, now you're intersecting the ascending portion, even though the patients began on the plateau portion. The active expiration artifactually creates this physiology. So now when they inspire, they release active expiration, they actually have a decrease in right atrial pressure, but all along they've been on this plateau portion. So this patient would be a fluid non-responder, but would have a decrease in right atrial pressure because of this active expiration. So this just goes on to show you that you have to rule out active expiratory efforts if you're going to use this lack of change in CVP during inspiration as a marker of volume intolerance. Okay, so a little bit more about dynamic CVP assessment. So if the lack of change of CVP during spontaneous inspiration is a marker of volume intolerance, can we say that a change in CVP during spontaneous inspiration is a marker of preload responsiveness or volume responsiveness? And unfortunately, the converse is not true, and it probably has to do with this gray zone of the cardiac function curve where it's in transitioning from, quite obviously being on the ascending portion to moving towards the plateau portion. So the closer you get to the plateau portion of the curve, the less volume responsive they're going to be. And if you're very close to that plateau portion, you may get a change in CVP with respiration. But if you were to volume load this patient, they wouldn't get very much cardiac output at all. And so this, you'll have a decrease in your CVP with a spontaneous inspiration in this patient, and this will be accentuated. This physiology will be accentuated if you're very close to the plateau portion of the venous return curve. So as you move the cardiac function curve leftwards with a inspiratory effort here, talked about this, you're clearly going to get a drop in your right atrial pressure, but this patient is so close to their volume, so close to the plateau portion curve that they're going to be volume intolerant. Okay, so unfortunately the converse does not hold true all that well. It's okay in studies, but it's not great. And this will be accentuated by very pronounced inspiratory efforts, like if this cardiac function curve is shifting way to the left. And that's common in ICU patients who are very short of breath. Okay. So what about, so that was predicting volume responsiveness in patients with spontaneous inspiration. So what about predicting the application of mechanical ventilation to patients, whether or not that will change cardiac output? Can you predict what their cardiac output will do with the application of mechanical ventilation based on what their CVP does when they're spontaneously inspiring? So it's reasonable to think that patients with an inspiratory drop in CVP during spontaneous ventilation, kind of the physiology we just saw as the cardiac function curve shifted leftwards, it resulted in a drop in the CVP, that if you were to initiate mechanical ventilation in those patients, which will shift the curve rightwards, it's fair to assume that those patients should all therefore land on the ascending portion of their cardiac function curve. And that's basically what I just said here. Okay, so how does this play out? Well, the decrease in intrathoracic pressure will shift the cardiac function leftwards, as we saw. You'll get the decrease in right atrial pressure. So in this patient, you would expect that the application of mechanical ventilation should reduce cardiac output by shifting the curve rightwards. But this did not prove clinically useful. So why did the cardiac output not decrease, i.e., why was the cardiac output preserved with the application of mechanical ventilation in these patients? And the reason probably lies in the adrenergic response. Now remember that PEEP does a few things. So PEEP changes the venous return curve, okay? It shifts the venous return curve rightwards relative to when they were spontaneously breathing. And this occurs mostly because of the adrenergic response that you get to PEEP, that the increase in adrenergic tone that you get in response to PEEP causes an increase in the stressed volume, so shifts your mean systemic pressure rightwards. Also, the application of mechanical ventilation pressurizes the abdomen, which also decreases the venous capacitance, okay, and probably increases your mean systemic pressure, shifts the curve rightward. It shifts the maximal venous return, the plateau portion of the venous return curve, the maximal venous return, it shifts it downwards. But you can see that the application of PEEP does not decrease the gradient for the pressure gradient for venous return, as most people say in the ICU. It actually may, theoretically, it could actually increase the gradient for venous return. What PEEP does is it lowers maximal venous return, and it actually tends to increase the resistance to venous return. You can see that the slope of this curve is shifted downwards. So that rightward shift in the venous return curve defends cardiac output. And then also the cardiac response curve may shift up and to the left with the adrenergic response. Remember, the adrenergic tone is going to increase heart rate, which will increase your cardiac function up until a point. and it will also increase your contractility. So these changes defended cardiac output with the application of PEEP, so it made that prediction invalid, unfortunately. So with the application of PEEP, this is what happens, and then if you were to apply a breath on top of that, you may have some changes in cardiac output, but these are not steady state, and this is also tempered by the increase in venous return with each inspiration. So we just saw that with pressurization of the abdomen with each breath, the venous return curve shifts a little bit to the right, and then with expiration it shifts back to its baseline at PEEP. So again, those changes, you can see that with inspiration and expiration, where the cardiac function curve intersects the venous return curve, that tends to defend cardiac output as well. So what about the patient who's on mechanical ventilation with PEEP? You can see the change in the venous return curve as a response. And the patient who's mechanically ventilated, can you use the increase in CVP with inspiration to predict that the patient is on the ascending portion of the cardiac function curve, right? So it would be reasonable to assume that if the patient were on the ascending portion of their cardiac function curve, that if you shifted the curve rightwards with a breath, then CVP would increase with the breath, and that would predict volume responsiveness. But for the same reasons we saw in the last slide, that the increase in CVP occurs just with a breath, that can occur in response to the increase in venous return with that breath. So this tends to increase your CVP with the breath, like this. Okay, so even though this patient is on the plateau portion of their cardiac function curve, that is, this patient is volume intolerant, the increase in CVP that you see with a mechanical breath like this, CVP clearly increased from there to there, this patient cannot be said to be a fluid responder. And that's just a function of changes in venous return that occur with breaths. Then you might wonder, well, this patient's on the plateau portion of their cardiac function curve, so like patients with spontaneous inspiration, would a lack of change in CVP predict the plateau portion? And what we just saw, that a patient who's on mechanical ventilation who does not have an increase in CVP with a breath is actually a very rare clinical event, and that's because of what we just saw. That's because of what we just saw. That is, when you give this patient a breath, venous return, you tend to squeeze blood as the abdomen is pressurized. You increase your venous return, that defends cardiac output, and it tends to result in an increase in CVP. So a patient with an absence of an increase in here's some logic for you. An absence of an increase of CVP is actually pretty rare to find. Okay, so a little bit more about dynamic CVP assessment. The situation becomes incredibly confounded when the patient's on positive pressure ventilation but maintaining spontaneous inspiratory efforts. And an example would be a patient on say CPAP or BiPAP. These patients are getting positive pressure, but they're also initiating breaths their own. We've seen this physiology, that the application of pressure throughout the respiratory cycle that occurs with CPAP or BiPAP results in a steady state rightward shift of the cardiac function curve and a decrease in the maximal venous return. However, with the spontaneous inspiratory efforts, the cardiac function curve will shift leftwards, but to a completely unpredictable degree, because you really don't know what kind of inspiratory efforts these patients are generating without an esophageal probe or a PA catheter to judge changes in intrathoracic pressure. So the interpretation of right atrial pressure with a patient who is mechanically ventilated but generating their own spontaneous breaths is exceptionally confounded, and this is a very common situation for patients in the ICU, patients on spontaneous breathing trials. patients who are on SIMV with pressure support or assist control, the breaths that they're triggering would represent positive pressure with spontaneous inspiratory efforts. So this is another example of the superposition of the Guyton and Campbell analyses that I go through in the first 4 chapters. But unlike the patient with the extrapulmonary ARDS we discussed in the last section, this is a patient with emphysema who's being mechanically ventilated. So again, I've left out the pulmonary elastance curve, which in a patient with emphysema would be shifted to the right. It would kind of come up here and curve off this way. But this is the chest wall elastance curve. Remember, the intersection of the pulmonary elastance curve and the chest wall elastance curve defines FRC. So this is FRC here. This is the compliance of the respiratory system. So if you remember what it looked like in extrapulmonary ARDS, this is very different because the chest wall compliance here is normal or high, and the pulmonary compliance in emphysema is normal or high. But this resistance curve is much higher on the respiratory system curve, and that's from the emphysema itself. Okay, so what's going to happen if we apply PEEP to this patient? Well, you can go back to the previous slide with extrapulmonary ARDS and see that the pleural pressure will not increase as much because the chest wall compliance is preserved. Okay, and the cardiac function curve again shifts with changes in intrathoracic pressure. Okay, so this is just going through the mechanical events that occur during a respiratory cycle. So that was FRC to PEEP, and this is PEEP plus an inspiratory breath. Okay, so now just imposing the patient with emphysema on top of here. So let's say this patient hypothetically is hypovolemic from insensible losses because they're in a bad COPD exacerbation. So their baseline venous return curve is here, and they're hypovolemic, so they're shifted rightwards here. So what's going to happen when you apply PEEP to this patient? Well, the cardiac function curve shifts rightward, but let's say the patient has excessive West zone 2 physiology because they're so hypovolemic and their lungs are underperfused that with the application of positive pressure and the increase in alveolar pressure relative to pulmonary venous pressure, that is the definition of West zone 2, that actually afterloads the right ventricle. So you can see what happens to the cardiac function curve in this patient with the application of PEEP. This may actually afterload the right ventricle, shift the cardiac function curve down and to the right. The application of PEEP shifts venous return, maximal venous return down. It increases even more the resistance to venous return as splanchnic vessels are compressed within the abdomen, so venous resistance increases. And now you have to imagine, so this patient is now generating spontaneous breaths. So they start generating negative pleural pressures during the spontaneous breath, and they're not as negative. They don't shift to the left as much because of the application of positive pressure, but the expiratory pressures may increase with the positive pressure. So those patients are going to sort of breathe with this pleural pressure change. Again, it's intrathoracic pressure on the x-axis. So what happens? They inspire. What happens to the right atrial pressure? Keeping your eye on the prize here. It doesn't change very much. And then they expire, and it goes way up, okay? And then they inspire again, and it may not change all that much. So you can see that, you know, in patients with aberrations of venous return, pulmonary physiology, you know, abnormalities of ventricular function, with the application of positive pressure, which changes their physiology even more, depending on their baseline volume status, how it changes the venous return curve, and then with completely unpredictable pleural pressure swings during inspiration and expiration, it becomes very hard, if not impossible, to make an adequate clinical prediction as to whether or not this patient is on the plateau of their cardiac function curve and therefore would be volume intolerant, or they are on the ascending portion. And then this, I think what this example also demonstrates is that this patient is hypovolemic. That's part of their underlying pathology, and then the hypovolemia is actually making their cardiac function curve abnormal by shifting it down into the right because of the excess afterload in West Zone 2. And if this patient had coronary disease and was hypovolemic, they may shift their cardiac output, the cardiac function curve down into the right because of poor coronary perfusion. And so this patient needs fluid despite what this physiology is illustrating. Okay, so really what it comes down to is a good history and physical, which is what most of medicine comes down to. There's few silver bullets, unfortunately, in our profession. So that is the end of the third part of this lecture, and the following portion we're going to talk about the ultrasonographic evaluation of the IVC, and specifically dilation and collapse of the IVC.